Neologist, and he's also an associate professor in the Department of Health Research Methods, Evidence and Impact in McMaster University, and director of the Biostatistic Unit at St. Joseph's Healthcare, Hamilton. We're very grateful to have you here today, and he came here really early today from Hamilton, so ladies and gentlemen, please welcome him with a big round of applause.
Diagnosis of HIV, getting engaged in care, using your antiretroviral therapy, and then ultimately having viral suppression. And the idea is that at each point of the care cascade, there's an opportunity to improve your health outcomes and to reduce transmission rates. So, I would be remiss if I were to speak about the HIV care cascade and not talk about the 95 targets set up by UNAIDS. And the idea of these targets is that by 2030, 95% of people living with HIV would know their status. And of those who know their status, 95% of them will be on antiretroviral therapy. And of those on antiretroviral therapy, 95% of them will be virally suppressed. So this is our lofty target. And for context, Canada is currently at 89, 85, 95. So we are getting there, but we're not yet there. We're pretty close, but the biggest concern with the HIV care cascade, and since we're here talking about providing care for people who need it the most, is that even if Canada reaches 95, 95, 95, there would be subpopulations of Canadians who would not have reached 95, 95, 95. This would include women, this would include ethnic minorities, this would include men who have sex with men, and people who inject drugs, and other key populations. So I'm going to talk about key populations a little bit more, somewhat here, and somewhat later on in the afternoon when I'm talking about drug resistance. So again, 95, 95, 95 is another framework which is supposed to be a strategic response to HIV control. And the idea is that the first thing is, in order for people to know their HIV status, you need to increase awareness about HIV and let people understand that it's important for people to get tested, even people who don't feel sick, right? And then the next thing is also to ensure that people are taking treatments and that these treatments are effective, right? And that's the only way that we will get viral suppression. And one of the big picture aspects of the 95, 95, 95 is actually the collaborative nature of this framework and this goal. And the idea is that we can't achieve 95, 95, 95 in the hospitals alone. We can't do that in the laboratories. We can't do that in the pharmacies. We can't do that in the community alone, right? It's a community effort. Everybody has to work together, and it's collaborative. So the care cascade includes several key stages. The first is diagnosing HIV, and then staying retained in care so that you can actually receive your antiretroviral therapy. And if you're receiving the antiretroviral therapy as you should, and then you'll ultimately have improved health outcomes, especially viral suppression, which is the most important one. So let's start off with early diagnosis. Everybody here probably knows that the earlier your HIV is diagnosed and the earlier you start treatment, the more likely you are to have better outcomes, right? So early diagnosis is important, and earlier diagnosis is strongly linked to your ability to have viral suppression. So it's important for people to be diagnosed as early as they can, right? So people at risk should absolutely be taking HIV tests. People who are not at risk should absolutely be taking HIV tests. And that's the only way we can reach the first 95, if everybody is tested and everybody knows whether they are HIV positive or they're not HIV positive. And this is a huge concern because I have been involved in research where we ask people what their HIV status is, and then we do lab tests, right? And the concordance between what you ask people and the actual lab test is not 100%. It's in the high 80s. And the discordance goes both ways, meaning that there are some people who think they have HIV and they don't. And then the larger chunk of the people are the people who don't know they have HIV, right? So there's room for us to make more efforts in terms of improving the speed of diagnosis. The next thing is linkage to care, right? Once you're diagnosed, you absolutely have to be linked to care. And this is one of the key features of the triangle of care that we try to provide in Canada. As soon as somebody has an HIV test, the impetus is on the health workers to not let that person disappear in nature, right? You have to link them to care, link them to other places where they can receive the kinds of services that they require. So I'm going to talk a little bit about some of the work we're doing in this area in terms of keeping people linked to care, because we have to bear in mind that there are certain barriers that keep the people who need this care the most from actually being linked to care. This could be transportation, it could be housing, it could be legal issues, it could be immigration issues. There's a whole host of things. Now, we also need people to stay retained in care. And part of the research I have done in this area is related to the definition of retention in care, right? How do you define retention in care? Think about this as a relationship with your significant other. How often do you want them to text you? Once a day? 5 times a day? 10 times a day? Once a week? Once a week is probably not enough, right? Once a day, we are getting closer to the target. 4 or 5 times a day is what people do when the relationship is still fresh, right? So my point is just that retention in care, that relationship, that connection between the healthcare worker and the client varies. Not everybody defines retention in care the same way. Some people say you should have at least 2 contacts with the health services every year, right? For some people, the 2 contacts is going to the lab to get your lab results. For some people, the 2 contacts is going to the pharmacy to pick up drugs. For some people, the 2 contacts is going to talk to a psychologist, right? So it's never the same everywhere, but it's an important facet. You should have at least some contact with the healthcare system, and the data from all of those contacts should be captured in the same place, right? So everybody knows, the doctors know that even if you didn't come to talk to me, at least you went to see the psychiatrist or you went to the pharmacy and you actually picked up your medication, right? Previously, when you had to take medication every day, it was important for you to come every month and pick up your medication. Now you can have this medication dispensed for 2, 3, 4 months, and then now we have long-acting injectables, right, which you can take and you don't have to come to the hospital very often. So retention in care is something worth looking into. And then obviously there's antiretroviral therapy, right? Everybody who is diagnosed with HIV should be on antiretroviral therapy. And this is a relatively novel choice of how care should be provided. Previously, you could only get antiretroviral therapy when your CD4 count dropped to a certain level, right? But in more recent years, we've moved to the test and treat approach. You test if the person is positive, and then you start them on treatment immediately. So that's where we are at now, and that's where we're trying to keep it. And then obviously the last bit of the care cascade is getting that viral suppression, which leads to ultimate to the best health outcomes, right? So the people who succeed to have low viral load are less likely to have morbidity and mortality. And morbidity just refers to suffering. So hospitalizations, ER visits, opportunistic infections, and they're also less likely to transmit. Now, for all of these things to work, right, we need to use data. And this data comes from government sources, surveillance, and from research. But ultimately, we need to monitor how well people are doing along the HIV care cascade so that we can say for sure if we are reaching the 95-95 targets or not, right? So, there are also a number of innovative interventions which are helping to improve care along the care cascade. So there are things that can be done to help people initiate treatment so that people who are tested don't get lost to care. And then for those who have initiated treatment, there are several things which can be done to improve adherence. And among those who are, who are taking their treatment, there are other things that can be done to keep them retained in care. So I'll talk about some of the research on some of those things so that you can see where we are with things. But generally speaking, things are leaning towards virtual and technologically based approaches to help people engage in care. So I ran a project funded by the Ontario HIV Treatment Network, and part of what we were trying to do was to find what the effective and pragmatic interventions that could improve initiation, adherence, and retention in care, and also what were the barriers and facilitators to this sort of implementation. So overall, you can see that we want people to start from diagnosis, initiate their treatment, adhere to care, and stay retained in care, right? And then the expectation interventions, medication modification, health system modification, economic modifications, which are mostly just giving people money to take care of themselves. And you would find that a lot of the research has been done on adherence, not so much on initiation, and a little bit on retention, right? And then when we looked at the intervention by the type of authors' conclusions, you'll see that there were quite a few. Most of the positive interventions were from digital interventions, community-based, and diverse. So the idea here of diverse is important because the idea is that there is no single approach that will improve your engagement in care. So you need some counseling, some text messaging, some education, and some incentives, right? So you need a combination of things to help keep people engaged in the HIV care cascade. And then on the far end there, we just look at the kinds of key populations that have actually been included in research on the HIV care cascade. And while it looks like a lot of this has been conducted in African, Caribbean, and Black people, this is not data from high-income countries. This is research conducted in Africa, right? So if you were to look at the amount of research conducted on Black people in Canada, it will be much less. So this reflects the 70% of HIV infections that are happening in Africa and where most of the research is conducted as well. So the database we created includes 349 clinical trials on HIV published between 2015 and 2023. We updated it in December 2023. And it's curated by income level, the vulnerable population that was investigated, who delivered the intervention, the setting in which it was delivered, the intervention type, and the level of pragmatism. So I call to your attention the categorization by level of pragmatism, because the level of pragmatism is a direct proxy for how easy it will be for you to implement this in an actual clinical setting. The more pragmatic studies can be applied in a clinical setting, whereas the less pragmatic ones cannot, right? So there are some trials that say in order to improve people's adherence, they need psychotherapy 4 or 5 times a week. In a study, you can get people to come to the clinic 4 times, 5 times a week, but in the real world, that is virtually impossible, right? So those studies will be ranked as less pragmatic, and therefore we'll use that information with a pinch of salt. Now, when we started looking at the barriers and facilitators to improving the care cascade in Ontario, we did a mixed method study where we actually interviewed health workers and clients in a variety of clinics in Ontario. So we started off, we had data from Thunder Bay, Sudbury, Ottawa, Kingston, Whitby, Toronto, Hamilton, Guelph, and Windsor. Obviously we had more from Hamilton because that's where my friends are, but that's where we got most of our data from. And here's what we found. So interestingly, wherever you see green, that means there was an agreement between what the literature suggests is effective and what people were actually doing in the clinics, right? Where you see yellow means either people were doing stuff in the clinics that wasn't backed by literature, or there was stuff in the literature which wasn't being implemented in the clinics. So most importantly, I would just like to highlight the first row here, where it shows that mobile health, right, using text message-based things and apps and all of that is the one thing that worked to improve initiation of treatment, adherence to antiretroviral therapy, and retention in care, right? And it was in agreement from the literature and was also implemented in the clinics. So when we went forward to look at the barriers and facilitators, this was a qualitative style study. So we looked at barriers from the health worker perspective, and we also looked at barriers from people living with HIV. And some of the barriers which the health workers mentioned were patient apathy, some patients not having access to care, or they not having the expertise to implement some of the interventions which they said were effective. For example, if you say they need psychotherapy and in the clinics there is nobody to provide psychotherapy, and then it just won't happen, despite the health workers acknowledging that it's very important. And then there was also the workload, right? They're just there trying to provide care, but then there's that extra workload to enhance the HIV care cascade, which is something worth noting. And then also not having enough time to actually implement some of these interventions. But then some of the facilitators which the health workers found were client preparedness. It always helps if clients are prepared, right? So that's where education comes in from the point where the person is diagnosed for the first time with HIV. And then virtual care and integration of the cascade and client compliance. So the idea of the cascade, integrating the cascade, is that you do everything, initiation, adherence, and retention in one package. Right? You do one thing that is meant to help the person across the whole cascade rather than doing it in little bits. So again, I just want to point your attention to the fact that both for the facilitators, from the people living with HIV, and from the health workers, virtual care showed up. Right? So this is something that we can lean on, and is likely going to lead to cost savings if we can actively use virtual care to support the HIV care cascade. So the other thing, which is an opportunity for the HIV care cascade research and implementation, is that it's an opportunity to address health disparities. Right? People may have different outcomes because of social determinants such as housing, education, income, sex, gender, and all those things, right? So when you're doing HIV care cascade research and HIV care cascade care provision, it's an opportunity to create that equity, right? By identifying some of these factors and trying to act against them. So based on the work we did in the AC study, we were able to identify that a lot of Black people living with HIV had major concerns accessing HIV care. So what we did was we decided that we were going to support case management. Case management is a term that I'm sure everybody here has already heard of. And we decided to develop a tool that will support the case management. And the idea of this tool is that it creates a comprehensive list of things that you should ask. You know, if you want to ask somebody 20 questions, you might just forget one of them because 20 is a long number. But if you have a list that you have to go through, it'll help you to remember and not to forget exactly what you should be asking. So it was a study with a qualitative part and a quantitative part, so a mixed method study. And we developed a final list of items. And the idea is that these are items which health workers think are important for case management, and which people living with HIV also think are important for case management. And our list looks like this. So you need to ask them if they are linked to care, if they are adhering to their medication, what their current HIV health status is. You also need to check if they have insurance, because you could be recommending a number of things which might not be covered by the health insurance. So that won't lead anywhere, right? You need to look into issues like culture and language, if they need a translator, mental health issues, experiences of racism and stigma, which keep people away from HIV care. You also need to give the HIV knowledge. Sometimes it's just a simple knowledge barrier that is keeping people from engaging in care, right? And then there's also looking at their family situation. Some people spend a lot of their resources providing care for other people, which could be different if you know, the health worker knew exactly that that was the situation. Look into self-efficacy, what their financial situation is. If they're experiencing domestic violence, there might also be immigration issues which impact their access to health insurance and other things. Also good to check if they have a support system. When they leave the clinic, who is around them, who supports them to continue staying engaged in care. Do they have transportation issues? How do they get to the clinic, right? A lot of the HIV medications have to be taken with food. Do they actually have food to eat while they're taking these medications? Are their bills covered? This is a pressing concern for everybody in Canada, the high income versus the low income. If you haven't paid your bills, you don't sleep well at night, right? Talk less of trying to engage in HIV care. So those are things which we need to consider. And we are currently developing this tool, and we are going to be piloting it in a number of clinics here in Toronto, including the Mayo Clinic and Taibu. And we'll see how it works out and how health workers are able to implement this. And for each of these items, the tool will be linked to the resources that they can refer the patient to if they need any services in that regard. So, future directions in research. we need to look at innovative strategies, right? We've been doing HIV care for close to 20 years now. Some of the things we have done are working and we should continue, but there are newer things which we can be trying, right? Especially collaborative care, collaborating with the networks, getting community engaged, and also using technology. Now we have technology at our fingertips. We can use it to our advantage and make sure we can use that to improve the care cascade. So, in conclusion, enhancing outcomes in the HIV care cascade requires a comprehensive approach that addresses barriers at every stage, right? So we look at barriers for initiation, barriers for adherence, and barriers to staying retained in care. And if we focus on research and we use innovative interventions, and we also look into health equity, right? The disparities that people are experiencing, we can improve the lives of individuals living with HIV. A lot of my work is supported by these folks here, CIHR, WHO, the Ontario HIV Treatment Network, and St. Joseph's Healthcare Hamilton, where I work. Thank you.